moving into a very interesting topic, that is the etiopathogenesis of migraine. See, migraine is actually a tricky disease, okay, because the etiopathogenesis, there is an old concept versus the new concept, and with the advancement like in the field of functional MRI, we have gained new insights with regards to the pathogenesis of migraine, okay. See, migraine, this is more common in case of females, okay. And why does migraine occur? See, it's often a combination of genetic factors, environmental factors, and host factors. So complex interplay of all these factors results in migraine, okay. Migraine. Alright. Now if you see the individual entities, genetic factors, okay, I'm just going to see the genetic factors. See, if you ask me, is there a single Mendelian pattern of inheritance of migraine, or is there any single gene that is implicated? No. There are multiple susceptibility genes for migraine, but except for familial hemiplegic migraine, where the genetics is better defined, for the other episodic migraines, you are not quite sure what are the genes that actually cause it, okay. So that is it regarding genetic factors. It's again not well understood, but we all know that migraine is a disease with again a familial tendency. When you have a sibling with migraine, you are likely to have migraine more. So is when you have a family member that is affected with migraine, okay. So genetic factors are important, but still a lot of things are yet to be unveiled in the genetics of migraine. Hopefully in the near future we might be able to identify the possible causative genes, okay. So that is it regarding the genetic factors. And so is with the case of certain environmental and host factors, because environment, that there are certain factors that act as triggers for the migraine, which we have already seen. So these will be migraine triggers, okay. Alright, so and certain host factors are also postulated, but again, we are still not exactly sure why migraine occurs. Alright, now regarding the pathogenesis of migraine, you have old concept as well as a new concept, okay. You have an old concept as well as a new concept, okay. Now what is this old concept? What is this new concept? So the old concept was that it is basically known as the vascular theory, okay. It is basically known as the vascular theory of migraine, whereas the newer one is known as the neurogenic theory, okay. Vascular theory and neurogenic theory. Now what is this vascular theory and what is this neurogenic theory? Okay, see, vascular theory basically means that migraine is primarily due to certain vascular changes. Alright, now by which I mean, that you have already studied regarding the phases of migraine, right? The prodromal phase, the aura phase, headache phase, postdrome phase. So this theory suggests that the initial aura phase of migraine is because of vasoconstriction, cerebral vasoconstriction, whereas the headache phase is due to cerebral vasodilation, okay. So vasoconstriction versus vasodilation, okay. So that was the old concept. So the old concept said that, whenever there is a spasm of vessel or a vasoconstriction, there occurs some focal oligemia, okay, and that focal oligemia is the reason for aura, okay. And subsequently there is a vasodilation and a hyperperfusion which is resulting in the headache phase, okay. As simple as that. That was the old theory. But again, see, I told you with the recent advances, especially with regards to the functional MRI, once fMRI came, we identified that even in the aura phase, before the oligemia, there is in fact a phase of hyperemia, okay, which actually precedes the oligemia, which means you cannot equate aura with oligemia, okay. So we understood, okay, this is not just about oligemia, because just before the oligemia there is some hyperemia, only after that oligemia is coming. So because of which we understood that in migraine, It's not just about a vasoconstriction and subsequent vasodilation. There is something else. And that made us, go into the theory of the neurogenic theory. Okay. Now, what exactly is this neurogenic theory? That is what I'm going to tell you. Okay. See, basically the neurogenic theory states that migraine is a disease of a brain. Okay. I'll put it in this term. It is a disease of a maladaptive brain. Okay. Maladaptive brain. All right. Very important. Maladaptive brain. Now, what do we mean by this? Basically, it means migraine is a brain disorder and not a vascular disorder per se, as was previously thought. This is primarily a brain disorder with secondary vascular effects. Okay. So, a primary brain disorder, but yes, vessel involvement is there, but it's basically the secondary vascular effects. Okay. Secondary vascular effects. But all these actually happens in what? A maladaptive brain. There is something that is wrong with your brain. Okay. So the brain is the seat of pathology in case of migraine. So what is this exactly? How does it occur? So the neurogenic theory goes like this. You have to understand that there are certain sequential steps that occurs in the pathogenesis of migraine. Okay. The neurogenic theory states that first of all, there is a migraine generator, number one. Okay. So first there is a migraine generator. There is a migraine generator. Now what is this migraine generator? See, migraine generator means where the migraine actually starts. If you remember, you learned regarding the phases of migraine. What was the first phase? The prodromal phase. Now, it was thought that this prodromal phase is possibly due to activation of what? Hypothalamus. Okay. So, the migraine generator initially was thought to be due to a hypothalamic involvement. Okay. So, hypothalamic involvement. Okay. But later it was understood it is not just hypothalamus. You also have the role of brainstem. Okay. You also have the role of brainstem. Now, if you ask me, where exactly migraine starts, hypothalamus or brainstem? Answer is, we still do not know. Okay. So, basically it is thought that there is a hypothalamic brainstem network which is affected, and that is causing the initiation of migraine. Okay. So, by which I mean, in fMRI studies, it was shown that when migraine started, there was simultaneous activation of these areas, that is both in the brainstem as well as the hypothalamus, simultaneous activation. So it was understood that, okay, it's not one area, it starts and then goes to the second. So it's that almost simultaneously activation of hypothalamus and the brainstem. Okay. So these two areas get activated together, and now it's called a hypothalamic brainstem axis, and some people also call it hypothalamic pontine axis. Okay. Because it's the key areas are located in the pons. So that is what you call the migraine generator, where the migraine actually starts, the migraine pathology starts. That is migraine generator. Now, once there is activation of this migraine generator, then what happens is you have to have something known as cortical spreading depression. Cortical spreading depression. Okay. Now, what is this cortical spreading depression? Okay, what exactly is this cortical spreading depression is what we are going to learn. Okay, so cortical spreading depression. So something that is initiated in the cortex and then spreads. All right. See, the cortical spreading depression or CSD, first of all, understand that this is primarily responsible for the aura. Very, very important. Cortical spreading depression is responsible for aura. Number two, what is this cortical spreading depression? See, in the cerebral hemisphere, okay, from the occipital lobe often, okay, from the region of the occipital lobe, you can have a wave of depolarization. a wave of depolarization from the occipital pole and from there spreading anteriorly. Okay, some wave of depolarization. Okay, some wave of depolarization that is starting in the occipital pole and goes anteriorly. Now, what exactly is this? This is basically some fluctuation of the ionic current that occurs in the cortex, and often it occurs in the occipital region, and this moves forward at a rate of 2 to 4 millimeter per minute. Okay, this is very, very important. This is a potential question. What is the rate of spread? Okay, so it moves at a rate of this wave of propagation at a rate of 2 to 4 millimeter per minute. And when this wave of depolarization spread, it goes and activates certain areas, which results in certain manifestations. Okay, that is why you get manifestations like a scintillating scotoma. Okay, so and it goes forward. So mainly the visual manifestations of the aura phase, you know, the most common type of aura is the visual aura, is due to the activation of the region of the occipital lobe. Okay, and then what happens is that, you know, once this wave of depolarization goes past a particular region of brain, then there occurs repolarization. Okay, so when repolarization occurs, what will happen? You will have the opposite effect, which is why in the phase of depolarization you can have positive features like a scintillation. Okay, whereas in the repolarization phase it goes to a scotoma. Okay, which means the patient cannot see anything in that part of visual field. Okay, so the depolarization is primarily responsible for the positive visual phenomenon in the aura, I mean. Okay, and the subsequent repolarization causes negative visual phenomenon. Okay, important. Depolarization, repolarization. Now this spreading wave is not confined to vascular territories. Okay, this is not like it goes in the region of posterior cerebral artery alone or middle cerebral artery alone. It does not obey vascular territories, which again is supportive of this neurogenic theory. Okay, which is that it is not primarily a vascular problem, because had it been a vascular problem, it would have obeyed the vascular territories. Okay, so it does not obey the vascular boundaries. Very important. It does not obey vascular boundaries. All right. Okay, does not obey the vascular boundaries. So that is cortical spreading depression. And one very, very important MCQ point is, so this cortical spreading depression is the electrophysiologic equivalent of aura. Okay, it is the electrophysiologic equivalent of the aura. Very, very important. Okay, it's, you know, if somebody asks you why aura occurs in a patient, it's because of cortical spreading depression. All right, CSD that causes the aura. All right, so we have already seen regarding the migraine generator and regarding the cortical spreading depression causing the aura. Okay, now third step, what happens is, you know, there is the headache phase. No, after the aura there occurs the headache phase. Okay, so regarding the headache phase, why there is headache? Okay, why there is headache in migraine? Okay, previously it was thought that, you know, it's just because of vasodilation, but no, it's not just because of vasodilation. It's because of certain other effects. Okay, now I'll tell you why this occurs. See, first there is migraine generator activation, then there is cortical spreading depression, then there is activation of something which is known as the trigeminal cervical complex, which you can abbreviate as TCC. Okay, trigeminal cervical complex. Okay, so basically there is activation of trigeminal cervical complex, and I'll tell you what is this TCC. Okay, now let's see. Now see this figure. I am sure that you would have seen this in Harrison. See the brainstem in this picture. Okay, you know that the brainstem houses the trigeminal nucleus. Okay, so you can clearly see the TCC that is labeled here. Okay, you can clearly see the trigeminal nucleus. You can clearly see the trigeminal nucleus. You can see it is extending into the spinal cord, and tell me the trigeminal nucleus extends till what level? C2. Okay, it extends till the C2. Okay, so you have the trigeminal nucleus, and what else are you having? You have the trigeminal ganglion out here. Okay, you have the ophthalmic division, maxillary and mandibular division, and together this trigeminal nucleus, the trigeminal ganglion, ophthalmic, maxillary, mandibular division, together you call it the TCC or the trigeminocervical complex. So once there is a migraine aura, there is activation of the trigeminocervical complex. Now if you ask me, see, you said, first aura occurs and then activation of trigeminocervical complex happens. But aura does not occur in all patients. Only 20% of patients have aura. It's true. So there is a gap there. There is a knowledge gap there. We are exactly not sure in how in patients without migraine aura, how the activation of trigeminocervical complex occurs. Okay. But that activation is a very, very important step for further initiation of the cascade of events in migraine. Okay. So basically I mean there is a trigeminocervical complex activation, and subsequently what happens is that there is a release of vasoactive neuropeptides at the trigeminal nerve endings as well as the trigeminal nucleus. Okay, so there is a release of certain vasoactive neuropeptides. And what are these vasoactive neuropeptides? These include, very, very important, can be asked for your exam, CGRP. Okay, CGRP, then vasoactive intestinal peptide, VIP, nitric oxide, substance P. Okay, substance P. The most important one is the CGRP, which stands for calcitonin gene related peptide. Calcitonin gene related peptide. So CGRP. Okay, CGRP. Now these vasoactive substances or neuropeptides are released at the endings, by which I mean you can see that, you see this, you can see that in this particular region that is highlighted, it's basically a zoomed section of the dura and the vessels in the dura. Okay, we have already seen that they are pain sensitive. So these, at the trigeminal nerve endings there, the release of these substances occurs. And once that substances are released there, that results in the plasma protein leakage and neurogenic inflammation. Okay, so the release of these substances results in what? It results in neurogenic inflammation. Okay, neurogenic inflammation. Okay, now this neurogenic inflammation also results in what? Plasma protein leakage. Okay, plasma protein leakage. Okay, some inflammation has occurred. Now what should happen? This inflammation, for it to produce pain, you have to have the involvement of the brainstem as well. So if you notice this picture, you can see that, you notice the position of the arrow here. Okay, you can see the arrow going here. So basically from the efferents, the trigeminal efferents, these are actually taken into the brainstem. And in the brainstem, you have certain processing areas like the raphe magnus, the locus ceruleus, the dorsal raphe. There are certain centers there, and also the rostral ventromedial medullary regions. So these are certain processing areas in the brainstem which has to process the efferent impulses, because some neurogenic inflammation occurred in the periphery, impulses are brought to the brainstem, there occurs integration at the brainstem. But remember, it's not just about the brainstem. you will have impulses going from the brainstem to higher centers, by which I mean the thalamus. You can also have impulses going to the hypothalamus. Okay, so there are ascending pathways as well, and subsequent, not just in one direction, though it's not shown here in this picture in Harrison, there are descending pathways also from the cortex, from the thalamus to the brainstem, which will help to modulate the pain. Okay, and that is how you experience pain in migraine. Okay, so summarizing everything together, okay, so there is the first migraine generator, cortical spreading depression, the headache phase, okay, release of neurotransmitters, neurogenic inflammation, brainstem, processing pathways go to higher centers, there is again a reverse direction flow also, modulation of pain, and you experience the pain of migraine. Okay, so that is basically regarding the current concept in the pathogenesis of migraine.